So like Neil said, my name's Sarah Milnes. I'm a midwifery lecturer at the University of Leicester on our 4-year undergraduate Master in Science, Midwifery with Leadership. And I'm here to tell you about a primary piece of research I did for my own Masters in advanced midwifery practice. So pregnancy and childbirth are life-changing experiences, and a person who's been on that journey can remember with great clarity that experience. You tell anybody that you're a midwife and you immediately get all of their birth stories right the way through, regardless of the age of the person that's telling you. You know, they remember really, really well. And as humans, we have very clear memories of events of significant emotion. And I bet the majority of people of a certain age could say where they were when they heard about 9/11 or where they were when they heard about the London bombings. And the reason for this is the amygdala, part of the brain that's associated with emotions, preferentially retains emotionally arousing experiences and influences the consolidation process and how we form them as memories. If the brain's exposed to threat, the amygdala will produce cortisol, send the brain into the fight or flight. And what the cortisol does is it suppresses the rational part of the brain, the hippocampus. When the threat subsided, the hippocampus can then make sense of the situation, and the situation can be stored as a normal memory. The amygdala can then access these stored emotions, and it can alert the brain to any similar situations that might then cause further threat to the body or the brain. The problem is traumatic events are stored as fragmented memories, sights and smells, things like that. And the amygdala views these in black and white, safe or unsafe, whereas the hippocampus can recognize these grey areas in between. However, the amygdala is what's activated first in the brain. So if it comes across something that's very similar, that it sees as a threat to the body can have a sudden unpredicted panic if they're put in a triggering situation. So for the majority of people that experience any sort of trauma, the anxiety and sadness will subside when the trauma is no longer the focus of their lives. However, if the memory is not properly processed, the brain will remain in a fight or flight state, and that can result in a state of constant alert, avoidance, or an unpredicted reaction in a certain situation. So it's estimated that 25% of women experience birth trauma, and these are statistics prior to COVID, so we don't actually know the extent of it yet. And 30% of these women go on to develop post-traumatic stress disorder, which is a condition where memories of trauma, they just don't fade. And anything they experience, a similar emotion or a similar sensation, is associated with and can cause flashbacks. For 15% of people who experience post-traumatic stress, there can be a delay in these symptoms for months or even years. So they may not know the effect that this trauma has actually had on them. And birth trauma is not always a dramatic event. It doesn't have to be an obstetric emergency or something that happened that was deemed very traumatic in the physical sense. What a lot of women report is that it's a lack of control, a lack of choice, and a lack of compassionate care that actually contributed to their birth trauma. So why is this important, and how does this relate to students? Well, the evidence suggests that mature student midwives, one of the catalysts for them starting their training and coming into midwifery is their own birth experience. And this can be positive or it can be negative. So in a positive sense, they want to come in and they want to emulate what they experience with the women that they're caring for. Or if it's negative, it might be that they don't want somebody to go through what they went through themselves, and therefore they come into the midwifery training to stop that happening to other people. One of the issues is the first year is a complete focus on physiology. So we focus on universal care, on what people consider to be normal, how the body changes in pregnancy, how labour and birth should go. And due to placement capacity, we can't put all these students on a birth centre to experience those physiological births. A lot of them go to a labour ward. So they're very quickly exposed to additional care needs. They're quickly exposed to the medicalisation of childbirth. And if these students have any unresolved trauma, or they're not aware that the trauma was even there, that can potentially have an impact on them when they go into clinical practice. And that's what I wanted to find out. So I did a literature review, and I couldn't really find any evidence that someone's personal birth experience affected the care that they provided. But some of the secondary outcomes from some of the studies that I did come across, there was a little bit of a focus on this, but there's no primary research that I'm aware of that has been done so far. So it was a small study because I had time restraints because I was doing a master's and I was doing it over about 8 months. And I took a hermeneutic phenomenological approach, approached students at a Midlands university who had either given birth vaginally or by caesarean section prior to commencing their midwifery training. And I used semi-structured interviews to explore their own experience and what they'd seen when they've been on placement and what they've seen in clinical practice and how both of those experiences made them feel. 10 students agreed to participate and saturation was reached after 6. The rest was scanned and the themes that were found tended to be the same as the first ones. So the first theme that came out was quality of care. So all 10 students that were interviewed envisaged having a normal pregnancy, normal childbirth when they were pregnant with their first. However, they reported that they had a lack of choice and control, which they then associated with negative experiences. They did say that if the care was compassionate, though, they reported really positively. So if the healthcare providers were compassionate, although it wasn't the labour they thought that they were going to have, they reflected positively on it. Some found that their negative experience had a big impact following birth, and a lot of them spoke emotionally about feelings of disappointment, failure, and anxiety. And they did realise that it's not the type of birth that they have, but the quality of care that was linked to the outcomes. Despite their experiences, they all reported that they still align to a physiological philosophy of birth, which is partly what brought them onto the course. However, like I said, the curriculum begins with universal care, and this isn't always what they then see when they go into practice. So the majority of students were really quite shocked at the complexity of care that they were seeing really early on in their midwifery programme. They expected to see care that was more aligned to the philosophy of the taught material in the classroom. They didn't expect such high levels of intervention. They reflected that women's choice was less important when additional care is required. And actually, when women were transferred to delivery suites, they found that physiology was rarely promoted. The third theme I called the road to redemption. So initially, before they went out on their placement, 4 students were quite anxious about their labour ward placements. They were concerned that they were going to be put in a similar situation to what they'd experienced. They didn't know how it would affect them. However, whether a student had a positive or negative experience, when they found themselves in a situation to their own, so a room or a hospital or a person that might be looking after them, it brought back very clear and very, very vivid memories that were quite unexpected. One student was so traumatised that she had to go home. She didn't anticipate the impact of watching a caesarean section would have on her, because the care the woman was getting was very similar to her own, and she just about held it together to finish the operation, and then she had to leave. 2 students who had experienced postpartum hemorrhages, so quite significant blood loss, reported that when they conducted a physiological third stage on placement, it made them really anxious. They just expected something to happen. They only kind of felt happy about it when the third stage was complete and the blood loss was minimal. 2 students had reported accessing psychological support, which they found quite beneficial. So they went to a birth reflection or something similar. And interestingly, 9 out of 10 students reported that they thought a debriefing exercise prior to going on their first placement would be really beneficial, because it might help them disassociate their own feelings with what they're then going to see in clinical practice. The multi-para students who were interviewed said that their second birth was quite healing. They described it as redemptive, which is why I've gone with the road to redemption, because they educated themselves and they found out their choices, and they came into that subsequent pregnancy feeling more in control. So despite their experiences, the students remained that they were aligned to the physiological philosophy of birth. However, because every single student had an emotional response when they returned to a familiar place, and these reactions were varied, some were positive, some were negative, the important thing is they were all unexpected. So what we know about the unconscious mind is that it recognises patterns, and this can play a role in clinical decision making. The evidence out there suggests that midwives keep negative experiences in mind, and it makes them practice defensively. It can alter the choices that they offer to women in their care. And I think in a subconscious way, from what I found out from talking to these students, that could perhaps happen as well. Because they have a very quick exposure to additional care, us as educators have a duty to support them, and we need to be considering ways that we can help them disassociate their own experience. So the recommendations to come out was students need a safe space and they need time to talk about their own experience and be able to step away from that. They come onto the course as a novice, as a mother, that's their experience. We need to help them through that journey to finish as an expert. So they're finishing as an expert that can walk away from their own experience and not impart that on other people and on the care that they're providing for women. Restorative sessions with a professional midwifery advocate might be quite beneficial, or a birth trauma specialist, again, prior to when they go on placement, and also to link in when students see other women's trauma when they happen to be on placement. So when they get that vicarious trauma, they might need some more input with that. But the main thing is further research is needed to see how we as educators can support students who are mothers, but also students that bring with them a preconceived idea of pregnancy and birth from what they may have seen on the TV and social media through other people. And I do really think that by providing this support, it might help attrition rates. I think we might be able to keep some of the students on the courses. So the first paper from this research, it has been published in mid-ears and it was out this month, and the second one is coming out in December if anybody wants to read the full papers. And thank you for having me. And I'll just finish on a quote, which I've actually put in my dissertation. I think it's quite powerful. So we are the sum total of our experiences. Those experiences, be they positive or negative, make us the person we are at any given point in our lives. And like a flowing river, those same experiences and those yet to come continue to influence and reshape the person we are and the person we become. None of us are the same as we were yesterday, nor will we be tomorrow.